Okay, we will start the prostate cancer part 13. Watchful waiting observation for untreated cancer. Active surveillance versus watchful waiting. Active surveillance for untreated prostate cancer involve routine follow-up and testing with intent of providing curative treatment if the cancer increases in risk. This option is typically used in men with low risk or very low risk prostate cancer whose life expectancy is more than 10 years. Watchful waiting, also known as observation for untreated prostate cancer, does not necessarily involve routine follow-up and testing. This is determined on individual basis. The intent is to administer palliative therapy if the patient's cancer progresses to a point where cancer-related symptoms are imminent or already present. Watchful waiting is typically used in men with non-metastatic prostate cancer, M0, whose life expectancy is less than 5 to 10 years. Which men are eligible for watchful waiting? For men with very low risk or low risk or intermediate risk or N0, M0 prostate cancer. Observation is preferred management in men with no cancer-related symptoms and with life expectancy less than or equal 5 years. The AUA 2017 and ASCO 2016 or life expectancy less than 10 years, that's EAU 2021 and NCCN 2021 guideline. For men with high risk M0, M0 or N1, M0 prostate cancer, observation is an option for the management of men with no cancer-related symptoms and with life expectancy less than or equal 5 years. Men with cancer-related symptoms or with metastatic prostate cancer, M1, should be treated. Follow-up and intervention during watchful and waiting. Watchful and waiting for untreated prostate cancer does not necessarily involve routine follow-up and testing. This is determined on an individual basis. If testing is done, it might include history and examination to check for development of cancer-related symptoms, BSA, creatinine, alkaline phosphatase, bladder ultrasound to check for rising dose, void residual, and renal ultrasound to check for hydronephrosis. Additional prostate biopsy are typically not indicated. The intent of a watchful waiting is to administer palliative therapy if the patient's cancer progresses to a point where cancer-related symptoms are imminent or already present. There are no universally accepted trigger criteria that define when cancer-related symptoms are imminent. Some possible triggers are discussed below here. The BSA and BSA doubling time, the NCCN 2021 guidelines suggest using BSA more than 100 as trigger. The EAU 2021 guidelines suggest using BSA more than 50 or BSA doubling time less than or equal 12 months as trigger. The EAU recommendation is likely based on study by Studer 2008, which is indicate that untreated men with stage T0 or T4, N0, N1, or M0 are more likely to die from prostate cancer if they have BSA more than 50 or BSA doubling time less than 12 months. The risk increases starting in 1 to 2 years with the 7 years of death from prostate cancer reaching 48% in men with BSA doubling time less than or equal 12 months and 32% in men with BSA more than 50. Therefore, men who have life expectancy of more than 1 to 2 years and who have PSA doubling time less than or equal 12 months or a PSA more than 50 may benefit from initiating ADT before symptoms or metastasis develop. Also, it is unclear if this improves their survival. Asymptomatic progressive increase in both void residual that is caused by prostate cancer. Asymptomatic urethral obstruction that is caused by prostate cancer from the primary tumor or metastasis. Active surveillance for untreated prostate cancer. Active surveillance for untreated prostate cancer involves routine follow-up and testing, with the intent providing curative treatment if the cancer increases risk. This option is typically used in men with low risk or very low risk prostate cancer whose life expectancy is more than 10 years. Men considering surveillance should be counseled on the risk of life-threatening progression. Active surveillance is different. That's watchful waiting for a comparison. The data used to determine eligibility for active surveillance. It is important to accurately characterize the patient cancer to reduce the risk of missing aggressive features that may produce surveillance. Beside the recent PSA digital rectal examination and the initial biopsy pathology, additional tests such as those listed below may be used to determine the eligibility for surveillance. Prostate multiparametric MRI. Several guidelines recommend using prostate multiparametric MRI to help select patients for active surveillance. Some guidelines also recommend obtaining both systemic and multiparametric MRI guided biopsy to determine the eligibility for surveillance. AUA and SAR 2019 guideline, it is strongly recommended that the multiparametric MRI be performed in men considering active surveillance. But the evidence is inadequate to establish that multiparametric MRI guided biopsy is a required step in the pathway for active surveillance. EAU and EANM and ESTRO and ESUR and SIOG detective consensus 2019 were inclusions in active surveillance. All patients need multiparametric MRI at some point, and prostate biopsy should be performed by multiparametric MRI guided targeted biopsies with systematic biopsies. NCCN 2021 consider confirmatory prostate biopsy with or without multiparametric MRI to establish candidacy for active surveillance. Confirmatory biopsy, this is a second prostate biopsy, typically within 1 year of diagnosis, used to help detect higher grade and or higher volume cancer that may have been missed on the initial biopsy. The result can help determine eligibility for surveillance. There is debate regarding whether a confirmatory biopsy is required for active surveillance. If the initial biopsy consisted of an adequate systematic and multiparametric MRI guided biopsy, then a confirmation biopsy is generally unnecessary. If the initial biopsy was only a systematic biopsy, then obtain multiparametric MRI if not already done, and perform multiparametric MRI guided biopsy and another set of systematic biopsies. If the confirmatory biopsy is done soon after the initial biopsy, 1 to 2 months later, and the initial systematic biopsy was adequate, then the additional systematic sampling can be omitted. If multiparametric MRI is not available, perform through systematic confirmatory biopsy. The technique of confirmatory biopsy is discussed below. The technique for a systematic component of the confirmatory biopsy, sampling should include at least same number and location of core used for initial systematic biopsy. However, the data suggests that it is also important to sample the anterior apical peripheral zone and anterior transitional zone on repeat biopsy. 25 to 50% of the cancer have foci in both the anterior apical peripheral zone and other area of the prostate. Thus, biopsy patterns that do not sample the anterior apical peripheral zone will underestimate the amount of the cancer in 25 to 50% of cases. Anterior apical peripheral zone biopsy are important in men on surveillance because they improve estimation of cancer volume. In 48 men who progressed on the surveillance and underwent radical prostatectomy, Defield et al. 2009 found that the dominant cancer nodules was located in the anterior prostate, especially the anterior transitional zone in 42% of cases. Thus, surveillance biopsy should include cores from the anterior prostate, including the anterior transitional zone, so that a significant cancer is not missed. Some urologists obtain more than 10 to 12 cores, example, saturation biopsy, when performing systematic biopsy during surveillance to minimize the risk of underestimating the amount of cancer. Molecular tests, it is not known if patient outcome can be improved by using this test to guide clinical decision. In men who have a worse prognosis based on this test, the clinician may consider treating the patient or performing more comprehensive and more frequent surveillance tests. Examples of this test include Polaris, Oncotype DX, the DISFER, and ProMark, all this discussed previously. Which men are eligible for active surveillance? Men with aggressive prostate cancer, such as intraductal and cribriform, and men with non-adenocarcinoma prostate cancer should be excluded from active surveillance. So those who have aggressive cancer, such as intraductal and cribriform, and men with non-adenocarcinoma prostate cancer should be excluded from active surveillance. Very low risk or low risk prostate cancer, the NCCN and AUA and EAU and ASCO recommended active surveillance as performed management for men with life expectancy 10 years and either very low risk or low risk prostate cancer. Factors that should be considered in the decision for active surveillance include patient age, cancer volume, and ethnicity. Men who are diagnosed at young age and who have long, more than 20 years life expectancy are more likely to be affected by cancer in their life. Also, men with African ancestries or high cancer volume more than 2 positive core on systematic biopsy have high risk of progression. For men with very low risk of prostate cancer and life expectancy more than or equal to 20 years, curative treatment is a reasonable alternative. For men with low risk prostate cancer and life expectancy more than or equal to 10 years, curative treatment is a reasonable alternative. Very low risk and low risk cancer have a low rate of metastasis and cancer-related deaths from 10 to 15 years after diagnosis. If men with very low risk prostate cancer undergo a radical prostatectomy, pathology show Gleason score equals 7 in 23%, Gleason score more than or equal 8 in 1%, and locally spread outside the prostate in 8%, 7% have extra capsular penetration, and 1% have a seminal vesicle invasion. As discussed previously, adequate evaluation of the cancer before enrolling patient in active surveillance may help ensure that these adverse pathological findings are not missed. Favorable intermediate risk prostate cancer active surveillance is an option for select men with favorable intermediate risk prostate cancer. However, surveillance in this men has higher risk of metastatic than curative treatment. The best candidate for surveillance in this group may be men with clinical stage less than T2A, PSA less than 10, and 33% of core positive and 10% Gleason pattern 4. Low risk on a molecular tissue test might lend support to an active surveillance. Active surveillance is not recommended for unfavorable intermediate risk or high risk or metastatic N1M1 prostate cancer. Follow-up testing during active surveillance. The goal of the surveillance testing is to determine if progression of the cancer to more threatening state has occurred. When progression occurs, curative therapy may be administered. The optimal surveillance protocol is unknown. Active surveillance should include testing at planned interval routine testing, even in the absence of clinical gains. Tests should also be performed when there is clinical change suggestive of cancer progression testing done for clinical indication. The recommendation tests for routine monitoring are PSA, digital rectal examination, and prostate biopsies. Multiparametric MRI may be used routinely, however, routine use of molecular tissue testing is not recommended. The AUA, EAU, and NCCN all recommend performing routine PSA and digital rectal examination during active surveillance. The recommended interval for this test are shown below. Here, this is the routine PSA and digital rectal examination recommendation during active surveillance, and this is a guideline. AUA 2017 that not specifies doing PSA per months, not specified doing digital rectal examination per months, but the EAU 2021 those specify doing this for 6 months. Here is specified doing digital rectal examination every 12 months. The NCCN 2021 also is the same like EAU 2021, but if more than 6 months is the duration for PSA, more than 6 months, duration for data more than 12 months, but the ASCO that mentioned that 3 to 6 months doing PSA or less than 12 doing digital rectal examination. The chart shows guideline recommendation for routine use of multi-parametric MRI, and also this chart here showing the multi-parametric MRI, and also prostate biopsy during surveillance. This is guideline 2017, 2021, and NCCN 2021 and 2016 ASCO. AUA 2017 consider doing multiparametric MRI recommended. Not specified interval, but it recommends doing multiparametric MRI in active surveillance. Prostate biopsy recommended by AUA, but the duration is not specified. Molecular marker is not recommended by AUA. The EAU not specified the multiparametric MRI and not specified the biopsy and not specified the marker. The NCCN 2021 recommend doing multiparametric MRI for period of more than 1 year, more than 1 or equal 1 years. Also recommend doing biopsy, prostatic biopsy. The interval more than 1 year, but not specified doing the molecular marker. The ASCO 2016 not recommend doing the multiparametric MRI and also recommend the biopsy. Recommend the biopsy with duration of 2 to 5 years, but not recommend molecular recommendation, molecular marker. Multiparametric MRI, prostate MRI Men with abnormal prostate multiple myeloma tumor have an increased risk of progression during surveillance. Men with a normal multiple myeloma tumor can still have clinically significant cancer among men on surveillance for low risk or very low risk cancer that have normal multiple MRI. 10 to 30% will have unrecognized BT3 or Gleason more than or equal 7 cancer reliable enough to assess for progression in men undergoing surveillance. Multiple parametric MRI should not be used as a replacement for prostate biopsy during active surveillance. Multiple parametric MRI can be particularly useful in men on surveillance who never had a multiple parametric MRI and whose PSA arise despite minimal cancer on prior systematic biopsy. This man may harbor an undetected high risk cancer. Surveillance prostate biopsy in this routine surveillance biopsy refer to prostate biopsy that is preferred at the planned interval during routine surveillance, not done for clinical care. A trigger surveillance biopsy refers to biopsy that is performed because of change in the clinical circumstance. The NCCN and EAU guideline states that surveillance biopsy should be considered if prostate exam changes in multiple parametric MRI more aggressive disease suggests more aggressive disease or PSA increase. So we'll do biopsy if we have a change in the prostate examination, the direct examination. Also, MRI show change, more aggressive change or more aggressive disease, or we have increase in the PSA. Therefore, we recommend to do multiple biopsy. The AUA 2017 guideline did not specify any trigger. It should be noted that the PSA kinetic and prostate exam are unreliable for detecting progression of prostate cancer. So the AUA and SAR 2019 guidelines state that the biopsy during active surveillance should include systematic and multiple parametric MRI guided samples. Technique for systematic component of surveillance biopsy sampling should include at least same number and location of core used for initial systematic biopsy. However, data suggests that it is important to sample the anterior apical peripheral zone and the anterior transitional zone on repeat biopsy. The following factors increase risk of progression during surveillance: abnormal MRI, PSA density more than 0.15, higher cancer volume, example, more than 2 positive core on systematic biopsy, and African ancestry. The PSA doubling time does not appear to predict progression in these settings. Approximately 30% of men undergoing surveillance for localized prostate cancer will detect to have treatment within 5 years. The optimal trigger for determining the needs for curative treatment are unknown. Trigger may include appearance of Gleason pattern 4 or 5, cancer increase in cancer volume, cancer found in more than a core, or tumor bulging into or invading into the prostate capsule. Men whose life expectancy declined to less than 5 to 10 years may be transitions to watchful and waiting. The cure rate is similar for men treated at the same time of initial diagnosis and for men treated as the time of initial progression after close surveillance. There are no proven methods to prevent progression during surveillance. A diet technique and smoking cessation during surveillance have no proven benefit, but they may be reasonable. Androgen deprivation during surveillance is not recommended. 5-alpha reductase inhibitors are not recommended to prevent progression during surveillance. The randomized REDEEM trial show that dutasteride does not prevent pathological progression during surveillance. However, retrospective data with long-term follow-up suggests that the 5-alpha reductase may reduce pathological progression during surveillance. This is the end of part 13. We'll meet again in another one. Bye.